Stop sharing the slides till you talk.
So, Dr. Ashish, can you just stop sharing the slides for a minute?
Thank you, sir. Thank you, sir.
Right. So I, on the behalf of Delhi IAP and Institute of Child Health, welcome you all for this important session, webinar. So today we have none other than, as a chairperson, none other than Dr. Singera Velu. He is a professor of pediatrics at Karaikal. He's also an IAP vice president for 2024. And he has lot on his biodata. He has been the district chairman of the Polio Pulse RI district. Central EB members for 2026, 17, 19. He has been the best. He has received the Best Teachers Award, Best Doctors Award, Senior Pediatrician Award, Bala Gopal Raja Active Pediatrician Award. So full of awards. Welcome, sir. Thanks for accepting our offer of being a chairperson for this webinar. Thank you very much, sir. And over to you, sir, to introduce the speakers and the moderators.
Thank you, sir. Thank you for your introduction.
So can I introduce the speakers and the
Good evening,
moderators?
sir.
Okay.
Yes, sir. Proceed, sir. Proceed, sir.
Okay. So today we have Dr. Ashish Sani and none other than our Dr. Sharmila Mukherjee. Madam, she is very close to me and one of my seniors and the mentors at Kalavati and Children's Hospital. Welcome, ma'am. Welcome, sir. So I don't think so I can be that big enough to introduce Sharmila madam. Everybody knows her, but few words of her would be really, I would like to mention. She's a director professor at Lady Hardinge Medical College. Her field of expertise are early childhood development, development pediatrics, development neurology, research methodology, medical education. She is a national scientific coordinator, IAP Project Nurture, member Government of India Expert Group of Disability, member India Government of India Expert Group in ECD. She is a managing editor of Indian Pediatrics and she is also an ex-editor of Indian Pediatrics Case Reports. Welcome, ma'am. And Dr. Ashish is a senior consultant, unit head at Shri Action Balaji Medical Institute, New Delhi. He is running a development clinic at the hospital for last many years and member of NNF, IAP, and he has many publications to his credit. And sir has been deeply and actively involved with all activities of IAP. That's why I welcome sir also. Over to Sharmila ma'am and Ashish sir.
Before that,
Sir.
good evening to all. Just it's a formal as a chairperson. I should thank the Delhi branch on my behalf as well as to Alok Bhandari and Mukesh. And I'm very thankful for including me as a chairperson. And I'm very happy that Dr. Ashish and Mukherjee madam is the right person to moderate this session because she has dedicated her career and especially I've been associated with her for the past 4 years. When ECD was introduced in 2020, she was my teacher rather. I underwent a training ECD as a TOT. Then I was able to spread it. TOT I have conducted. It is not a madam because of you, the module came out very well and I could spread the module throughout Tamil Nadu. Really, I conducted more than 15 programs personally. I took part. It was got a very good response. So you are the main person behind it. Because of you, it has a very good impact to the pediatrician. I'm really happy that you are here and I am being with you. And Ashish sir who is going to talk about a very important aspect in pediatrics. So development and normal milestone is important. It's for the postgraduates as well as for even practitioners because everybody used to forget after some time what are the main I love today, madam and Ashish are definitely going to give a very good. I really appreciate Delhi branch under the leadership of our Alok Bhandari and Mukesh sir, and they have given me the big honor to be with you all today. I think this is the second time in their teaching schedule they included me as a chairperson. Thank you, sir. With this, without wasting much time, we will listen to the academics today and over to moderator Madam. Thank you, ma'am. Thank you. Thank you, Mukesh.
Right.
Thank you. Thank you so much, sir, for those very kind words. It was IAP Nurture was a complete teamwork, and it could never have been successful if all of us had not pitched in together. And I thank IAP Delhi for inviting me. And Dr. Ashish is a very close buddy of mine. So, so let's start off. Dr.
Yeah.
Ashish, please.
Yeah, thank you so much, sir, and thank
introduce
you
a
to
slide.
Dr. Alok Bhandari and Dr. Mukesh for giving us the opportunity. I think I and Dr. Sharmila, this is the fourth session we are moderating. She's become a chronic moderator of mine in last 1 year. I think this last 1 year she's been. This is the fourth one. We did it one for North Delhi IAP, then one in PCNI, and it's always been a pleasure because she always hits the nail on the head. This happened in the morning also when we were sharing the slides, and those lacunae. So I'm really and fortunately for me, I've got used to her moderating. Now I think I can't I can't moderate or present a session without her. So anyway, without further ado, let's start on the session. I would really love to have inputs from both sir and Dr. Sharmila in between the presentations because their knowledge would really kind of complement the whole session. So let's start. We start with the screen sharing now. Is it visible to everyone?
Yes, I can see it.
So milestones to us pediatricians is like the backbone of our subject, right? Like without milestones, there is no pediatrics, I would say. And this is something which we were taught from day one once we entered pediatrics until today. I think we are all learning. It is such a vast topic that I think I thought it was a very small topic to begin with. But I think as I interacted more and more with my old books and with my dear colleague, Dr. Sharmila, I came to realize there's so much more to it than what I thought. Anyway, we'll be tracking these milestones now, and we'll be taking a very horizontal view and a very vertical view of the milestones. What I mean by that is we'll be taking a vertical view of the four major domains, and then we'll be taking a horizontal view also in a cross section of the milestones at different ages which need to be asked by the postgraduate students. So what really is a milestone? What are milestones? Now, if we go by the literal meaning, it is like Bangalore is 30 kilometers. That is a milestone which we normally come across. That's the literal meaning. But for us in pediatrics, that holds no purpose. They are actually markers of a child's development from infancy to childhood. And they are used to help determine if a child is undergoing typical development, that is very normal development, versus if a child has any delay in a given area or over multiple areas and in the process of aging and development. So that when we pick up these milestones, when you ask the history for milestones, which is much more important than maybe even eliciting them from the mother, it helps us realize where does the child stand. Is he normal or is there a delay or a lag? So what is child development? Child development refers to how a child becomes able to do more complex things as they get older. And development is different from growth, right? Now, growth only refers to what we say as weight and height and the child getting bigger in size. Development refers to the overall development of the child, how he's developing cognitively, how he's developing in his other milestones. And milestones are the cornerstone of assessing development. And there are various tests that are conducted based on the milestones for the first 5 years, which in turn decide on how the development is going. Whether it is slow, whether it is faster, whether he's developing in all domains or whether he's lagging behind in some. And most importantly, need a very good milestone history from the parents. And development depends on two major features, that is nature, which is genetically and antenatally determined to some extent, and nurture, how we bring up the child, and that is partly reflected by the milestones of the child. So when it comes to perinatal and prenatal factors, you have genetics, chromosomal abnormalities, multiple pregnancies, drugs and infections in pregnancy, metabolic diseases, placental and uterine problems, and whether the child is born as IUGA, SGA, large for gestational, prematurity. All these are factors which affect the development. And environmental factors are how the child's nutrition is. A malnourished child might be lagging in some milestones temporarily. And any emotional deprivation, as we commonly see in children who are brought in foster homes or in orphanages, where the emotional component is not to such a great extent, They might have certain features which might look like whether they are not interacting, they look like autistic, or they might be very introvertish. So we need to take those factors into consideration. So what are the principles of milestone development? We all know they are cephalocaudal. The milestones start from the head. We first see a head lag vanishing in a child, head holding comes, and then the different caudal, that is then the sitting comes, then walking comes. It is proximal to distal. You obviously have a child first moving his shoulder, then the finer grips coming, and same is with first sitting and then the walking. When the lateral part or the later part of the legs take shape and they turn from proximal to distal, the development, and general to specific. A 2 or a 3 month old child, once you're laughing or interacting with him, will move all his limbs, will move his whole body. But when it comes to as he grows up, then it becomes more specific. There is a social smile, then there's a hand regard, then there is hand holding. So these are the principles of milestone development, which we need to keep in mind. And is development history normal? Is important.
Can I just interject here? Yeah. Dr. Ashish, you've beautifully told us about the milestones and what it is, but can you just elaborate upon, like, why is it important for, as you said in the beginning, it's important for the students, it's important for the pediatricians. So for the student in particular, since this is a PG class, predominantly our DCH and our diploma students are going to be attending, why is it important for them? So suppose they get a child with nephrotic syndrome, or they get a child with a ventricular septal defect. Why should they utilize their precious time to take developmental history and the milestones?
No, because I think all these, like as I said in the environmental factors, if he has a disease, so those milestones might show some lag, which might be temporary. So in that case, you need not put the child into a label, or you need not put the child as being delayed in development. Like if the child is not well, he's ill for some reason, there might be a temporary lag. Like you have meningitis, he might be a temporary lag, and once he recovers from it, there might be a catch-up growth and even the milestone development. Any input from you?
Yeah, for me, I'll say that I like, now I'm talking in terms of an examiner. For us, when we take the examination, we always try to see what the student knows in the must know areas. And if the student can answer the questions in the must know areas, then we will pass that student. So the way immunization, the way anthropometry, the way assessment of dehydration is a must-know area, that way the developmental milestones is a must-know area. So even if you have a child who is and developmental history is an essential component of the history. So even if you have a child with a systemic illness that does not involve development or delay, or does not involve child neurology, pediatric neurology, even then it is essential to take a cursory developmental history. And obviously, if you have a neurological or a developmental component, then you take it much more in detail, which Dr. Ashish is going to be talking about. So please continue, Dr. Ashish. Thank you so much.
So development history, is it important? I think we had a discussion, I was discussing with Dr. Sharmila around a few weeks back, that in children, at times, developmental history, as she said, was even more important than virtually eliciting the milestones. Because at times, when the child is with the doctor, whether he's in the ward or whether he's in the OPD, the surroundings are new, the surroundings are different, the child might not be comfortable, and it might not be very easy to elicit all the milestones. So in this case, the mother's reading or the mother's outlook is very, very important, and we should really give a lot of importance to it. And this history is not only important for as pediatricians, even for the geneticists, psychologists, anyone who's dealing with children in any branches. We have to take a detailed history, which will start in case there is a lag. We have to start from prenatal factors, perinatal factors, any relevant illnesses, as Dr. Mukherjee rightly pointed out, if she has a nephrotic or even the non-neurological illnesses might cause a temporary lag. An assessment of rate of development, whether the development was delayed in all milestones, in some milestones, or were all milestones delayed, all gross were delayed, or sometimes you have a child who's maybe sitting normally at 6 months, but when it comes to walking, he might not walk till 18 months. So a very detailed history and relevant history is needed. We need to have a familial pattern, although not too much importance is given to it, but you have familial late speakers, when the father was talking late and the child would also be talking late. And so a history of achievement is to supplement one's own observation is very, very important. I think I would say 70% would be history and 30% would be, if the child is cooperative enough, we could elicit the milestones. And in preterms, please remember, especially for postgraduates, we take milestones are taken at term corrected age in preterm infants and not chronological age till around 2 years of, till the child is 2 years of age. So what are the domains where they fall into? Gross motor, fine motor, language, communication, social or emotional, and cognitive. Now, I mean, when I'm sure Dr. Sharmila and I were studying, we never took that much of importance to, social, emotional, and language. We were too obsessed with gross motor, fine motor, because we saw very less of autism and psychological illness. Now, with the coming in of autism in such a big way, I think number 3 and number 4 are now as important as number 1 and number 2. Because a lot of social and emotional impact has to be given equally importance, looking at the amount of cases of ASD we are coming across. So what are gross motor domains? They are like walking, sitting, running, catching a ball, climbing stairs, walking down. Fine motor are like buttoning, unbuttoning, eating with a spoon, able to pick a pellet, where the fine motor, the hand movements are involved, I would say, or the limb movements are involved. And this domain, language and communication, is very, very important. We know a child communicates not only through language, but even non-verbal communication is very important, like need-based commands, normal conversation, finger pointing, PIP and DIP, as we say, following directions, and naming things in a book. Social emotional, this is about how children interact with others and they show emotions. He's calmed down when he's spoken to, or when he gets angry, why he's getting angry, he comforts others. Is he frightened? Like when he enters your OPD, a normal child meeting me for the first time would be very scared, or a child whom we are vaccinating would be very scared. These are very, very normal behavioral issues. If a child is very bold and he's not scared of me, or he's not even paying attention to me, that should ring a bell. Cognitively, this includes learning, thinking, problem solving, and how children learn new things, solve problems, explore environment. And simple things like making objects fall and then watching them is part of all the cognitive learning. Now, one thing I would like to, before we go to progression, is that when you are eliciting one milestone, I mean, you might be able to cover almost all 4, right? If a child is dropping a ball, he's picking up a ball. One is gross motor. You see the child picking up a ball with his hands. That tells us that he's able to take a grip. Then the fact that he's looking at the ball falling, he's able to pick it up, talks about his cognitive skills. So one has to not really, you can't be very categorical in saying this milestone, just this action covers only one milestone. We might be able to cover more than one milestone if we keep our eyes and ears open. So when it comes to progression of motor milestones, we see there are 4 weeks. There is ventral suspension. Head is held up momentarily. We all see that in newborns, in our nurseries, and they tend to then bang their head against the mattress. When they are pulled to sit, the head totally falls down. There's a complete head lag, right? At 6 weeks, head is held up momentarily in the same plane as the body for a few seconds, and maybe again his head drops down, and he's pulled to sit. There's considerable but not complete head lag. It improves. And anyone who's seeing a child serially coming would be able to make out, or the mother would be able to make out, rather that at 4 and 6 weeks, there was a difference. At 16 weeks, his head and chest is off the couch so that the face is at 90 degrees. He's like almost up at 90s. Held in the sitting position, his head is held up constantly, but it keeps on wobbling, right? It keeps on moving around. 20 weeks, the weight is on the arms. Head wobbling decreases. And the very cute gesture, that is feet going to the mouth. Which, apart from, I think, children, only Ramdev Baba could have done it better. And in standing positions, they bear most of the weight. At 24 weeks, they have weight on the hands and not on the forearms. And when they are pulled to sit, it lifts the head of the couch and it sits with support. At 28 weeks, here at around 7 months, that is, they start rolling from supine to prone. They sit with a hand on the couch and they bear weights on one hand. At 32 weeks, they sit without support. They're able to sit easily and they can adjust their posture to lean on an object and not fall, And some of them might go in for a little bit of tripod sitting initially at around 7 months, which they overcome usually by around 32 weeks. At 36 weeks, they are prone. They try to crawl, progress backwards. They pull to stand. They stand holding on to furniture and they can lean forwards but not sideways. So these are some few pictures that I took from my clinic also, and I took it from the net also. This is like a 4 to 8 week child who's sleeping with the head. This right now you cannot. Now this is the point. What Dr. Shamila and we were talking, that a child who's sleeping and who keeps on sleeping at my clinic, if I wake him up, he'll be very rudely woken up, and we might not be able to elicit milestones. In the same way, this child now there is no head lag, very less head lag. At around 12 weeks, we are able to pull to sit. Look at this 90 degrees. What a cute looking guy. He's looking at the examiners and he's giving them a very, very clear milestone. That is that he's sitting at around 90 degrees and he's supporting it with his one hand. And this is another person at around 16 to 20 weeks where he's sitting. He's able to hold his head up and he uses both his arms. Again, he's now able to even pull up his arms and look at you in the eye. And this is the progression. This is at around 6 to 7 months. The rolling starts from prone to supine and supine to prone at 6 to 7 and 7 to 8. And now he's sitting, but if you see he's sitting, there is some amount of tripod. He's taking a little bit of support from his hands, which is more clear in this picture. This was taken at the same time. And over here, the child is able to sit, pretty independently and even turn around to pick up a toy. Here he's sitting very comfortably without support at around 7 to 8 months. And this is when the crawling part starts, somewhere between 8 to 9 months, when they first start with bottom shuffling, and then they gradually come to, move around with all 4 limbs. Like he's now more active. He's pulled himself off the ground and he's crawling very well. And this is what I was talking about, crawling. He starts with one sit, then they start bottom shuffling, and gradually he comes on all 4s. This is standing with support at around, say, 11 to 12 months. And this is again standing with support, and he's able to move the stool and he's so comfortable doing it. Now, again, I would just plead with all our EG students that there are no very hard and fast rules, right? 1 month here and there does not mean the child is lagging in something or he's ahead in something. You can have a child who's sitting at 6 months also, or a child who's sitting at 7 months, and there might be some children who's sitting at 5.5 months. So please don't comment too early or whether the child is, ahead of the times or whether he's slow on the times. At 1 year, they start walking with one hand held and they may shuffle on the buttock and the hand. At 15 months, they walk without help. They creep upstairs. They can get into a standing position without support, and they can go around corners and they stop suddenly. We all see 15-month-old children going up the stairs, with both hands on the stairs. At 18 months, they can walk upstairs, one hand held, walks pulling a toy or doll, beginning to jump with both feet. 2 years, they run, they pick up objects without falling, and they can kick a ball without overbalancing. 2.5 years, they jump on both feet. 3 years, they ride a tricycle. This is a very important milestone. At 3 years, it is easy to remember also. And they go upstairs 1 foot at a time, but while coming down, they use both the feet on the same. 4 years, they go downstairs 1 foot again now, and they skip on 1 foot. And 5 years, they're skipping on both the feet. So after these gross milestones, we come to the fine motor. Any comments from Dr. Sharmila or Dr. Singrawal? Any inputs on this gross motors? Ma'am?
Oh, wonderful, sir. It's very clear. You can go ahead, madam. Madam comments.
Yeah, I'd like to comment after all the domains are over before you start with the cross-sectional.
Fine. So we go to the developmental and fine motor. 4 weeks, hands are closed, and we all know grass reflex is present. It's such a beautiful feeling. You give a finger on the hand of a child, and he really grasps it, and all the relatives feel that, this child loves him only. 6 weeks, the hands open. 8 weeks, again, they open, but the slight grasp reflex is present, although it is not full now. And by 12 weeks, usually the grasp should go. And they hold the rattle when they are placed in their hand, and they are able to, but the rattle is not sustained for too long. This is that beautiful grasp reflex that we see. At 16 weeks, the hand regard comes. Hand regard is when they wash their hand at a distance and intently watch it. And this is one thing is that is hand regard, what has to be known is a psychological, it's a fine motor milestone. And it is even present in the visually impaired. They play with a rattle, but they cannot pick it up when dropped. And at 20 weeks, they play with their toes. As I've said, they're able to put their foot in the mouth. They're able to grasp the object voluntarily, and mouthing starts. And this is the time when mouthing starts, and we all Indian grandmothers are obsessed ki teething shuru ho gaya, iska dant aana shuru. At 24 weeks, they grasp the feed, palmar grasp of the cube starts. 28 weeks, they are able to transfer the cube and feed self with biscuit to some extent. This is a picture of a child which is holding a rattle, and he's able to hold it. So he must be something like around 12 to 14 weeks. And then later on drop it, but they are able to sustain holding it. This is hand regard. Very clearly, he's looking at his hand so intently, he's not bothered who all are around. This is what we say that hand in the foot, what these children do. And at 36 weeks, pincer grasp comes, that they are able to hold a pellet with both their fingers, and they're able to compare two cubes by bringing them together. At 40 weeks, there's a release. They bring to let go of objects. Pellet, they are holding them very firmly, before around 10 months or so. And then they start releasing them. They realize that they need not hold it forever. And at 1 year, the mouthing stops and they begin to throw objects to floor with this casting. That is, they throw objects to floor, and then they realize they've done that. And then gradually by 15 months or so, they start looking at it. Where has the object gone? So that is kind of both fine motor and also cognitive to a large extent. And this is what we see with the cube. I mean, this is for us, as we say, immature grasp or mature pincer grasp. And like holding the cube at 7 months is first an ulnar thing. At 6 months, radial comes at 7. At 9 months, they're able to hold it with their 4 fingers. At 6 months, they're able to, push a pellet, but they're not able to hold it. They can't comprehend the fact that you have to hold a pellet. At 8 months, the pellet is gradually out of their hand. 9 and 10 months is a very good pincer grasp. It is very classically seen in normal children. If we ever have the time in our OPDs, I think we can always demonstrate it if the child is cooperative. This is kind of an immature pincer grasp. Unfortunately, I only had a matchbox, though I don't smoke at that time. And he was able to kind of show me a partial pincer grasp. At around 15 to 15 months, they start scribbling spontaneously. They're able to feed self, but they manage it with a spoon, but they're clumsy, as I would say, and they tend to spill over rather than going in the mouth. And they're able to form a tower of 2 cubes. At 18 months, there's a tower of 3 to 4 cubes. Now they are much better off with a spoon. They realize that they have to eat food. And if the parents are not spoon feeding him, he will spoon feed himself much better. And he makes the strokes imitatively. And 21 months, he makes a tower of 5 or 6 cubes. At 2 years, the number of cubes keep on increasing, 6 or 7 cubes, turns the door knob and imitates a vertical or a circular stroke. And at 2.5 years, he makes a tower of 8 cubes and holds a pencil in hand instead of the fist. So the fine motor, that is, now he realizes that the fisty thing, the way he was holding his pencil is gone. He realizes the pencil has to be held in a pencil grasp typically. These are pictures which can be used. You have to learn them obviously first, but they can be used practically even to elicit the responses, and they're not very difficult because you just need a few cubes and you just give it to a child and have the patience to see how they form a gate at 4 years, how they make a tower of 9 cubes at 3 years, and how they make steps at 5 years. This just shows that apart from the fine motor, apart from the gross motor, this is a cognitive thinking which is making them, make a train, which is helping them make a gate, helping them make a tower of 9 cubes. Like as you see, as these children, they are so engrossed. Colorful cubes, they add color to their life. That is another milestone. They are able to recognize color and they're able to name colors. Then they're able to make different things with the cubes. A pencil is a very good fine motor tool. If you don't have anything, if you're sitting in the primary health center, suppose, and you just want to do an assessment of fine motor, giving a pencil to a kid, at 15 months, he will imitate a scribble. At 18 months, he's spontaneous scribbles or makes strokes imitatively. At 2 years, he imitates vertical and horizontal strokes. And at 2.5 years, he holds pencil in hand instead of fist, and he imitates horizontal and vertical strokes. 3 years, he copies a circle. He draws man on request. Old psychologists were very fond of a good enough man test, where you would make a man. I had a very old psychologist living outside my clinic opposite my house. She was 80. And the only thing after retirement she used to do in a charitable institution was tell them to draw a man. 4 years, she copies the cross. 4.5, she copies the square. 5 years, triangle. And 6 years, diamond. So you can get a rough idea of where the domains are with just one pencil also. So when it comes to hearing and understanding, you realize that birth to 3 months, there's a lot of startle to loud signs, right? We find that agar OAE nahi ho raha hai, we don't have the facility of an OAE. maybe just banging the door or maybe shouting on someone. The child, if he's crying, he stops crying. If he's silent, he might start crying, which shows that loud sound has had some response to him. He quiets or he smiles when spoken to. You obviously are very thrilled when you speak to a 2 to 3 month old child and he looks intently and would give an occasional smile to you. He seems to recognize your voice and quiets down if crying. And this happens especially if there is when he hears the mother or the grandmother, whoever is the more primary caregiver, and increases or decreases sucking behavior in response to the sound. We all are familiar with the mouthing part, which starts at 4, and they start putting toys in the mouth and they start putting the hand. The moment you talk or you engage them in conversation, everything is lost and they start looking at you intently. 4 to 6 months, they move eyes around in directions of sound, responds to changes in the tone of your voice, notices toys that make sounds, and pays attention to music. At the latter half of the year, that is 7 months to 6 years, they turns and the child will turn. Not only will the sound impress him, he'll try to look where the sound is coming from. He'll listen when he's spoken to, like as if he tries to understand your commands. And that is how they learn, I believe, when you tell them later on, don't do this, yes, no, bye. And he recognizes words like cup, shoe, book, juice, say bye to the doctor. And he enjoys game like peekaboo, which is cha in Hindi, right, Dr. Sharmila? And in other parts of the country, you could have different words for it. And he begins to respond to requests. Like if you tell him to come here, maybe not at 7 months, by around at the end of the year, he'll start listening to these commands and kind of following them partially. At between 1 to 2 years, he points to few body parts when he's asked, right? Where is the ear? Where is the nose? And this is something which can be done in the OPD and very well answered by the mother, because she's always very proud that my child is able to tell the body parts. Follow simple commands like roll the ball, where is your shoe, kiss the baby, listens to stories, songs, and rhymes. A lot of children at 1.5 months, that mothers would say, he can say Humpty Dumpty, or he can. Nowadays, they have a lot of these YouTube videos which they show, which ideally should not be shown, and points to pictures in a book when named, and tell them there is a cat, there is a ball. They'll just point. They will not be able to narrate what the picture is, but they'll be able to point. So after these understanding, we come to speech progression, how that happens in children. And that is again very important now with the coming in of autism and seeing them left, right, and center. So talking at birth, he startled to loud sound, as we said, quiets or smiles when spoken to, and increases or decreases the sucking behavior. You can see that he can hear, right? So his attention gets diverted. Birth to 3 months makes pleasurable sounds like cooing, gooing, cries differently for different needs, smiles when he sees you. At 4 to 6 months, babbling starts. Like, he'll start off and the mother will say, haan, bolta hai. Like, they're very happy that he bolta hai. He laughs at times. Some of them have a louder laughter, which comes at normally at around 8 to 9 months when they, so कहते हैं खिलखिला के हंसते हैं, when they really have a hearty laugh. And 4 to 6 months, he'll make gurgling sounds when left alone. The salivation, they play with their saliva, and that produces a lot of sounds. 7 months to 1 year, the babbling has long and short groups of sounds like a tata, baba, bibi, upar. They start joining two syllables to some extent. Uses speech or non-crying sounds to get and keep attention. Uses gestures to communicate. Like he'll wave, he'll say bye-bye, he'll hold the father's hand to be picked up, or maybe pull at the trousers. Imitates different speech sounds and has 1 or 2 words like dog or dada, mama, usually around the first birthday, and says 2 to 3 words with meaning. Again, my request is please don't take all these milestones as have to be there. And if they're not there, something is wrong. There might be some of these milestones might be there in some children, some might be absent in the others. And if he says more words every month, he uses 1 or 2 word questions like bye-bye, what is that? Or who is that? Puts, or as very commonly we see when the parents come and ask us, the doctor kya karega? He'll point to his thigh, maybe injection. And he puts 2 words together like no juice and more cookies. And he uses many different consonant sounds at the beginning of words. 15 months may vocabulary increases. 2 years may they ask for drink, toilet, food, joins 2 or 3 words in sentences and starts talking. They talk. Some of them really talk a lot. After that, you come to visual milestones. We know that they start seeing, but the visual milestones get better. They're very short-sighted initially. So in supine position, 3 feet from the eyes, they'll be able to see an object and follows it less than 90 degrees, they lose interest. 6 weeks, they start following it as it moves from side to the midline 90 degrees. At 12 weeks, hard hand regard comes, dangling toy from side to side, 180 degrees, they promptly look. And at 16 weeks, immediate regard of dangling object. This is a very rough sketch of how they would see me or see their mom or see any person from 3 days to 1 year. Because it's very, they keep on asking questions. Now mothers keep on asking, Isko dikhta hai kya? Can he see me? And how well can he see me? And dressing and feeding, again, very important milestones, because they are not only, these are milestones which not only tell us about gross motor, fine motor, they also tell about cognitive, about his thought process, about his observation powers. Like we know that at 15 months, he'll be able to take off his shoes. He's able to feed self, manage spoon, but again, as we said, it rotates near the mouth. 18 months, rotation of spoon stops, but he's able to take off his gloves. He's able to take off his socks. 2 years, he puts on shoes, socks, and pants. At 3 years, he dresses and undresses fully if helped with the buttons. And 5 years, he starts tying shoelaces. General understanding and higher functions is, again, 6 weeks social smile, 12 weeks he squeals with pleasure, 20 weeks he smiles at a mirror image, 24 weeks he will drop a toy and look for it, right? And mirror smiles again and vocalizes. He sees his mirror image and he starts smiling at 6 weeks, 6 months, sorry. And at 7 months, he imitates, pats image and tries to make contact with the person. And by 32 weeks, he reaches for the toy and looks for a dropped toy again. By around, say, 44 weeks, that is around 11 months, he holds the object, but he does not release it. But by 48 weeks, he knows that he has to release the object. He shows interest in picture books. 15 months, mouthing stops, asks for objects by pointing. And they imitate their mother or even their, house helps in sweeping, cleaning. They will take a broom and they'll start doing it themselves. And 18 months, they point to 2 or 3 body parts. The domestic mimicry, as I said, goes one step further. And they turn pages 2 to 3 and they point to a dog or a car, whereas bobo, or car is going, so they'll say honk, honk, or horn. And by 2 years, point to 3 to 4 body parts, obeys 3 to 4 simple commands. And they're able to turn the pages simply. And by 3 years, they can name 8 picture cards. We have the picture cards in a lot of these hospitals or in our clinics. They're able to name 2 colors and they dress and undress well. So one thing which is very important while examining all these milestones, I put this at the end for the simple reason that these are mandatory. If child is hungry, uska dhyan is on the food. He's not going to pay attention to your milestones. If he's tired, he's not slept for 12 hours, he has been playing at home, please don't expect him to elicit the milestones to you. If he's very sleepy, if he's unwell, you are giving him some antihistaminics, he's drowsy, or he's irritable because of the cough and cold or URIs, please avoid those and call them at a later stage. So, any inputs, ma'am, Dr. Sharmila? Yeah, please.
Yeah. Before we come to the questions, can you just go back to the go back to the previous slide? Can you go back to the previous? Yeah, that's it. Just to summarize, Dr. Ashish has beautifully, Dr. Ashish has beautifully gone through all the milestones that have that emerge as the child grows older. So I'll just summarize a couple of things. As Sir said, the domains are gross motor. So the gross motor domains are basically the skills that arise from the large muscles that are responsible for the maintenance of the posture and ambulation. So you can remember the skills accordingly. Fine motor are those skills that emerge from the activity of small muscles. So here, small muscles, the first small muscle that we must remember is vision. So the small muscles, the intraocular, extraocular muscles, so your fixation, tracking, then the eye-hand coordination, eye-hand-mouth coordination, and then the hand activities. So again, if you remember the sequence like that, it becomes easier. Speech and language is verbal as well as non-verbal, gestures, etc. Personal social is the way the child interacts with the environment, whether the child is interacting with the inanimate or with the persons in the environment. The cognition domain is, you'll see when, like what Sir also told you, is that there's a lot of overlap with other domains, because obviously whatever you're understanding, only when you understand something can you perform. So that's why it's going to be a little difficult to ask those questions separately. And there is something called adaptive function, which is basically all these skills that a child utilizes in his activities of daily living, as sir very beautifully said, for dressing, undressing, etc., indicating hunger, thirst, etc. And apart from these domains, we need to look at the sensory functioning, which means the skills that are required, which give you a reflection of the child's hearing as well as the vision. So once you have these domains, once you have the skills, now you will probably have on your platter something like 200 skills. Now 200 skills, to memorize 200 skills is, it becomes very intimidating for a student. So I'll just give you a couple of tips which I share with my students. And also you have so many things. You have Illingworth, you have Ghai's book, you have Dr. Piyush Gupta's book, you have the Nelson, you have so many books and information on the net, you have webinars, and some of them are in weeks and some of them are in months. So it's for a student, what I would say, it's invest half a day, make your own notes, choose what you're comfortable with, whether you're comfortable in months, whether you're comfortable in weeks, make your own list of milestones and memorize them. And when you're making the list of milestones, remember the milestones are being used in two aspects of your assessment. One is the elicitation of history from the parent or the caregiver. And the second is when you're confirming the presence or absence of the milestones when you're doing the developmental assessment, which is going to be a very cursory bedside thing. It's not going to be a detailed psychological assessment that is done by a clinical psychologist. So when you choose your milestones, choose the important ones, choose the ones that a mother can easily observe and recognize. Because for instance, if you ask a mother that aapke bacche ko immature pencil grasp aaya hai, so she will not know the difference between an immature and a mature. In fact, lots of my third year PGs cannot tell me the difference between an immature and a mature pencil grasp. So your milestones that you want from the mother must be easily recognizable by the dadi, nani, anybody who is looking after the child, so that the information that you get is correct. And this, in the examination, you can look for the more complex skills which you as a pediatrician will be able to pick up. So once you make those skills, also remember that especially as the child grows older, there are certain skills that are opportunity based. Now, it was very interesting when Dr. Ashish was saying the skills which he said that the mothers are very proud to tell about. In our setup, in a government setup, when we get lower socioeconomic mothers whose literacy level are very low, you'll find mothers who have never taught their children anything about the body parts. A child will be 2 years old and they never even thought कि इनको बताया कि आँख है, or whether it's a nose or ear. The same thing goes for shapes. So these are the kind of skills which will probably be easily elicitable in a educated family or a higher socioeconomic family, but some not in a more rural or a more government setting. And it also depends upon the exposure. For language also, like what sir said initially, that you need to ask mobiles, and nowadays since the families are becoming smaller, you have less people surrounding the kid and interacting with the child, and you have a lots of families when both parents are working and only you have a nanny who's looking after the child. So in those instances also, asking the history of the milestones to the mother or the father may not give you the accurate information. So ask for the person who is looking after the child, the dadi or the caregiver should also be there as a part of, as an informant for giving you the history. Get from the history is what you're going to build the rest of your evaluation, whether the assessment of the child or whether your interpretation is whether the child is developing typically or atypically. So that is my feedback on what you have done so far. Wonderful. Let's proceed ahead.
Okay. Thank you, Dr. Sharma. Sir, any input from you, sir? So now
Wonderful, sir. You have done very clearly, and you made it very clear and extensively. You have done, sir.
So
I think, madam.
as Dr. Sharmila just now said, that you make your own, like you make your own questions and you make your own things which you need to ask, which you think you should ask the parents. So here is just a set of questions which you can ask. They will be covering some aspects in all age groups, like has he begun to smile when you talk to him? And when he makes noises as well as smile when you talk to him, does he smile? Uh, is it an occasional smile or does he smile meaningfully? Does he hold a rattle in his hand? Does he turn his head when he hears things? Does he go for a toy and place it in his hand? Does he pass a toy from one to the other? Does he hold a rattle and plays with it? Does he turn his head when he hears things? And when was that? And will he go for the toy and get it without being put into his hand? And does it pass it from one to the other? When does he sit without support on the floor, without rolling over? Does he creep on hands and knees? Does he imitate anything which you do, like making noises, putting your tongue out? And when is the time when you help dressing him? How much can he dress? How much can he undress? I think this helps in ADLs whenever we ask about children who are we find are maybe neurologically a little not up to the mark. Does he clap hands? Does he walk holding furniture? Does he walk alone with support? And when he was dry by day and when he's dry by night, how long does he play with the one particular toy? How does he imitate sweeping, dusting, and how does he compare in general understanding with his siblings? So this is very important, especially if there's a gross difference, right? Minor differences you have to tell the parents are even there in twins, like two fraternal twins or even identical twins can be different. But if there's a major this thing, then you have to really pick it up. Now, the reason why I chose these, obviously in consultation with Dr. Sharmila, was if you go, these questions can be asked in both a rural and an urban setting. Like none of these questions are such which need a device, or none of these questions are such which an uneducated or an educated mother might not be able to understand. So these few set of say around 15 questions can throw some light. Now we come to we've done the horizontal part. We now come to the vertical part of the milestone. That is, you have a child of 2 months. Now, what all basic things you will look at every month, at all of these months. 2 months, social, emotional, you calms down when spoken to. There'll be a lot of repetitions in what I'm going to say now, because now we are kind of breaking it up for you people into month-wise so that you can absorb them. And when you see a 4-month-old child, you know what all to look for. So he looks at your face. He seems happy to see when you walk up to her. He smiles when you talk or smile at her. Language and communication makes sounds other than crying and reacts to loud sounds. Either he stops crying or he starts crying. Cognitive watches you as you move to some extent, and then they obviously lose interest and looks at a toy for several seconds, maybe till around 90 degrees. Again, they lose interest. Movement of physical milestones, holds head up when on tummy, moves both arms and opens the hands briefly. At 4 months, smiles on his own to get attention, chuckles, not a hearty laugh, but just chuckles when you try to make him laugh, looks at you, moves or makes sounds to get your attention, and language and communication says ooh, ah, makes sounds when you talk to him and turns head towards that sound. These are at 4 months, right? And cognitively, if he's hungry, he'll open the mouth towards seeing the bottle or when the mother is about to feed him. And movement of physical may holds head steady without support at 4 months when you're holding him, holds a toy when you put it in his hand, uses his arm to swing at toys, brings hand to the mouth and pushes up the elbow. Now, one thing which I've come across quite frequently, and I'm sure our panelists also would have seen, that is holding the head steady without support at 4 months can vary between 4 to 5 months. But children who have a very particular lag are the ones which we see tend to throw their head, maybe not in the back, but even in the front like this. We have a lot of children who come with a head lag, and the parents are very quick to point out that the head lag is not in the front, but even in the not in the back, but even in the front. 6 months may knows familiar people in social, looks to self at mirror and laughs. And language may he takes turn making sounds, makes squealing noises. Cognitively, he puts things in their mouth to explore them, reaches to grab a toy, closes the lips to show. And when movement of physical milestones come, rolls from tummy to back and pushes up arms when on tummy, that it becomes more than 90 degrees and leans on hand to support himself. 9 months may social milestones, clingy, fearful around strangers. They realize that ghar wale apne hai, there's a stranger, there's a doctor, there's an outside person. They might not be very friendly. They show very facial expressions, several of them. They look when you call her name, they react when you leave, and they smile or laugh when you play peekaboo. Language makes a lot of different sounds like mama, dada, baba, and lifts arm. When you pick him up, they feel like they throw their arms to you that they want to be picked up. They bangs two things together. They get to a sitting position by themselves by 9 months to a large extent and move things from one hand to the other. They're able to pass a cube or a rattle from one hand to the other and sits without support. 1 year again, they play game with you like pat a cake, waves bye-bye, calls a parent mama, dada, understands no. Cognitive milestones may put something in a container, like a block in a cup. You give them a cup, you give them a ball, they keep on putting it, they'll take it out, they'll again put it. They look for things, he sees you hide like a toy under a blanket. They realize now things are being hidden from them. That kind of a cognition and understanding starts, that they realize that someone is hiding a thing, and the moment they discover it, there's a squeal of joy from them. And they pulls up to stand, they walk around with furniture and they drink from a cup without a lid. They drop a lot of it, but they're able to hold the cup and realize that a cup has to be brought to the mouth, and they pick things up between thumb and finger, like the mature prince of grasp. At 15 months, they copy other children. They show you an object she likes. They clap when excited. And this is very commonly seen, when in the clinics also. And they hug a stuffed toy and they show you affection. They can hug or cuddle. If these the parents, not the doctor, obviously, because he's the prime villain, because he's vaccinating them half the time. And language or communication, they look for a familiar object when you name it. They follow directions given with both a gesture and a word, like give me the toy, and they follow that gesture. They might partly follow it initially, and then they might follow it fully maybe in another month or so. And they point to ask for something or to get help. Cognitively, they try to use things the right way, like a phone, a cup, or a book. A phone nowadays, I think mobile phone is the thing, which again we try to discourage them, and they stack at least two small objects. Movement and physical milestones, take a few steps on his own and uses fingers to feed them. So the whole purpose of this exercise is that when you see a child of a particular month, these are few things that should come to your mind. And I'm sure both our panelists will add on to them. There are some things which are very, very important, which you have to look. You cannot ignore something like walking at 15 months and just think of cognition. That makes no sense, right? Even if he's cognitively good and he's lacking in some gross milestone, that has to be taken note of. It has to be a very comprehensive and a very holistic view that you should take at a child. And don't look at him like a horse with blinders, right? We have to be a horse without blinders. We should be looking at him from all angles. At 18 months, he moves away from you. He points to show you something interesting. He puts hands out for you to wash them, looks at a few pages, helps you dress him by pushing the arm through a sleeve or lifting up a foot. They realize now that this is the way our mom has been dressing up over the last few months. This is what we have to do. Says mama dada, starts vocabulary increasing 3 to 4 words, follow step one step, get the mobile, put the ball there, get your clothes, and which is papa's mobile, get the remote. These are the directions which they follow now quite a bit. And they play with toys in the simple way, like pushing a toy car, sweeping. I've said that they follow, whatever they see, they try to mimic. Walks without holding, scribbles, drinks from a cup, and feeds himself with fingers. Now, at 2 years, now we realize that gross milestones are almost over, right? A child started walking, he started running. Now the language communication becomes more and more important. Social, they realize if they hit their brother, younger brother, or an elder brother, the mom is going to get upset. They look at her expression, they look at the mom, they realize she's sad or she's angry, and they realize that this is not to be done. And this is the way, some children who are smart enough, maybe they hit the child again, hit their brother again, to see the reaction of the mom again. And so this is now that has to be observed. Language takes a very, very important seat around 2 years, points to things in books. Where is the bear? Where is the elephant? Where is the ball? Says at least 2 words, points to at least 2 body parts. This is at least 2 body parts, right? At 2 years, you find children pointing to much more than 2. And uses gestures like waving, pointing. And the favorite of all our Indians is, I think, doctor ko flying kiss de do. That is the most common thing that we come across. And tries to use switches, knobs, buttons. They try to fiddle with them in any way they can. And they play with more than one toy at same time, like putting toy food on the toy plate. The social, what we would say that they start mimicking things, and they start, when it comes to physical, now the milestones have come down to just running, maybe stair climbing, getting down the stairs, how they are doing that, and kicking a ball. Pretend play begins, right? They start feeding up their teddy bear with a spoon. They'll start playing doctor with a stetho at home. And at around 2.5 years, the vocabulary increases around 50 words. They say 2 or more words together with one action, like doggy run. And they say words like I, me, we. This is what we find in some children of ASD or autism, where this 50 words is badly lacking. And some of them might be using the third person while they are talking all the time. Like Ashish bol raha hai, ya Dr. Dhankar bol rahe hai. He would not say that मैं बोल रहा हूँ. That use of noun or pronoun might be lacking. And uses simple things to pretend, shows simple problem like standing on a small stool to read something. We all know we have 2.5, 3 years coming to the casualty. इसने thyroid, दादी की thyroid की दवाई खा ली, उसकी BP की दवाई खा ली, or he's put that silica in his mouth. They realize where the things are. They do not realize yet the severity or the seriousness of what they are doing. And he shows at least one color by around 2.5, 3 years, pointing to a red crayon when you ask. So that color recognition now comes. That's a fine, higher cognitive skills. And when it comes to movement, again, it is like going up the stairs 2 at a time. And while coming down, it might be initially 2 steps on the same stair, and then they start climbing down with 1 step at a time. 3 years, they calm down within 10 minutes after you leave her, like at a childcare drops. Social anxiety comes into play much, much more now. Notices other children, joins them to play. And language, they start talking in conversation. Usually by 3 years, they come, they tell home कि बॉबी ने मारा, अथर्व ने मेरा पेंसिल ले लिया, मैम ने फूड दिया. And that conversation is very heart rending for the, that is very, sorry, rather heart enlightening for the mothers, and they really enjoy it. And that is missing, and they're the first ones to point कि ये आता तो है पर ये बताता नहीं है कुछ. When he comes back, he doesn't tell us anything what happened in school, right? He'll tell us कि मेरे को potty आई है, सुसु आया है, खाना है, but that kind of a conversation, social conversation, is lacking. And he draws a circle when you show him how he avoids touching hot objects like a stove when you harm her. So movement of physical developments, nothing much now, puts on clothes by himself, uses the fork apart from a spoon. And at 4 years, he pretends to be something else. As I said, pretend play begins to a larger extent, comforts others who are hurt, like he will hug a friend, avoids danger, likes to be a helper, and changes behavior based on where she is. Like he knows कि स्कूल में शोर नहीं मचाना, घर में पंगा लेना. They know that they have to be well behaved in school because they will get scolding there, and at home they can tear their mother's clothes, books. They can do whatever they want. And language में they start sentences with 4 or more words, and they start stories, rhymes, and they talk at least one thing what happened during the day, like I played soccer, and answer simple questions like what's the use of a fork, how do you use a coat, what's the use of a short pants. Names a few colors, it increases, draws a person with 3 or more body parts. And movement they catch a large ball, they serve herself with food or pours water, unbuttons some buttons, and holds crayon or pencil string. Now, as I said and I mentioned before, like buttoning and unbuttoning is not such a simple task as it seems to us now, right? But for them, it is not just fine motor, it is even, the fact that they know where to put the button, how to button it. That means they have been observing that. So these things have a lot of other connotations apart from just fine motor skills. And 5 years they start almost behaving like a big kid, I would say, or a big child rather. Sings and dances or acts for you, does simple chores like matching socks, clearing the table because they see that the mom clears the table, so they start doing that, or rather the dad clears the table now. Tells a story she heard, which is made up of at least 2 events. Answer simple questions. They start reading books, right? They start getting, unfortunately, the culture is gone now and iPads are given in their hands. But I think if books are given to them, they have very good pop-up books now I've seen where they really enjoy that and they start telling stories and keeps a conversation going. They will cook up stories very well and counts to 10, name some numbers from 1 to 5. The number thing gets better. Addition thing starts, simple lines, straight lines happen, and buttons, some buttons, and hops on 1 foot. Any inputs from Dr. Sharmila, ma'am, on this?
Yeah, that was wonderful. I'll just tell the postgraduate something about my own when I was a PhD. And he used to get, and that was the time when I was, like reading the first year, reading those couple of those boring chapters in the beginning of Nelson, which you have no idea why you're supposed to read. And he told me that development is so interesting. And I looked at him, I mean, is this gentleman nuts or something? How can development be in my voice? And all the other pediatricians who are dealing with the development, we find it fascinating, but at your level probably you don't. It's only when you become a parent and when you deal classical music in the beginning, if somebody who has never been exposed to classical music listens to it, they find that it's some strange sound. But somebody who is an exponent later on understands the beauty of the music. So let me just put it this way, that like now when you do multiplication, when you do mathematics, you do it instantaneously, like this multiplication tables, 2 is to 2, 3 is 3, 13 tables, 15 tables, which used to be so traumatic when you were a young kid. The same thing applies. Memorize the milestones, and you need to be able to put the proper pieces in the proper place. So that's
your voice is breaking. Your voice is breaking.
Picture, so that once you have all the pieces in place, you can see what the age of the child is. There must be something with the connectivity. What I would say for the postgraduates is that go to the ward, pick up a child who is about to be discharged. Don't ask the mother the age, just ask whether the child is preterm or term. If it's and ask milestones in each of the 4 domains, and based on what the child's functioning is, based on the milestones, then you check whether the age that you have got matches with the actual age. And if you do that in a couple of cases, Ashish just told you. And another thing would be that if you can go outside your hospital, because remember, a kid who is coming to the OPD, a kid who is coming to the hospital, or even to the immunization center may not do those things because he's intimidated or because he's unwell. But a healthy child playing in a park, your own friends who have kids, if you go and meet them and you do this exercise on them, then you can actually, like, it's like practicing MCQs for your entrance exam. For your entrance exam, you sit and practice MCQs. For your case presentations, you go to the ward and you present cases. So take it like that, do this exercise, and you will build your own skills of how to do elicit a developmental history. And regarding the questions that you're going to ask, will extract information. But if you do not ask the question properly, you will not get the correct information. So when you are asking the questions, it should be like a conversation, gappe marne. You should have to chat with them. It shouldn't be like milestones which are very easy. Like, does your child walk? This is not open to kind of interpretation that the mother will not understand. But there are certain other milestones, like a social smile, for instance. So when you smile at your child, does your child smile back at you? So the list that I told you to prepare, in that same list, also add another column, which is the question that extract that information. Peekaboo or pat a cake. That if you ask a person who is from Delhi or from say Rohtak, ki pat a cake khelta hai aapka bachcha, so the mother will not understand what you're saying. So jo local language mein jo puchna hai, whatever the local language, the terms are, you must ask that. And if you feel that the mother is not understanding, you can always just point out to another patient, do it, or you demonstrate. So anything, any way, asking questions, demonstrating, pointing out other children, anything to get the correct information. Because once you get the correct information, then the next step of your evaluation continues. So that's all from my side. Sir, would you like to add anything else? We would love your inputs as well. Dr. Ashish, is sir there?
I mean, I can't see him here. Can't see him here.
Sharmila,
Yeah.
which sir are you looking for?
So you.
Is it? Yes, I'm there.
No, sir, we are also looking for.
Flags, because I think we're running.
Oh, Singaravallu has left,
Achha.
and
Yes.
others have also left. I and Lalan Bharti are the two people.
Okay,
who-
okay.
So
Okay, so
Lalan, why don't
Mukesh
we?
has left. Mukesh has left. He has some urgent work, so he has left.
fine.
Dr.
So,
Mukesh from IAP. So
we'll
thanks to
just-
everybody. Yes, sir. Yes, sir. Please go ahead.
we'll just continue then. As Dr. Shimila rightly pointed out, you have to act like a forensic guy, you know, and try to guess the age of the child by his milestones. Don't ask the mother. And going through all the milestones in all domains, when you look at the child, try to guess his age as close as you can, and then maybe you can ask the mother exactly his age. I mean, that would be a better revision of your milestones than anything else. So now we just give a brief red flags in development. When should your eyes and ears, your ears should stand up, and when should you should start looking here and there? Something might be wrong, right? So a quick reckoner at any age. Any parent who she says is something is wrong, you have to listen to her. You cannot say, "Nahi, nahi, ye to aise hi bol." I have burnt my fingers enough number of times in my practice of last 25 years to realize that whenever a mother says my child is unwell, I'm talking about the organic part, not about milestones. That means you have to give weightage. You can't say, okay, nahi, ye to aise hi bol rahi hai. So that has to be very taken with a lot of concern, especially if the parent says there's loss of skills, there is lack of response to sound or visual stimuli, there is poor interaction with adults or children, there is difference in the right and left sides of the body in strength, movement, or tone. Or if she says my child is very loose or flappy, or on the other side, if she says my child is very stiff, he's not able to, even bend, or he's not able to sit with support, even at 6 months or 7 months, forget about sitting without support. All these things have to be taken have to be given due importance. In gross, if there is not any rolling at 6 months, not holding head and shoulders when on tummy, no, hands are clenched, fine motor, not reaching for and grasping toys, not starting to babble in language, and does not smile or squeal in response to people. At 6 months, these are all red flags for you. 9 months, not sitting without support, does not take weight on legs when held. Fine motor, unable to hold or release toys, cannot move toy from one hand to the other. Language, no gestures, no pointing, no waving at 9 months at all. Social, not sharing enjoyment with others, not making any eye contact or facial expression. Very important, these milestones now, especially with the coming in of MChat and coming on of ASDs. Language and social have to be as important at maybe at 6 to 9 months as we give importance to gross and fine motor. Red flags at 12 months, not crawling or bottom shuffling at all, not pulling to stand, not standing holding on to furniture. Fine motor, no pincer grasp at all. Very poor suck and swallowing, persistent mouthing. Hand sucking was developed later in infants than in normal ones. Language, no response to familiar sounds, right? No babbled phrases that sound like talking, no single words by 15 months. And in social, does not notice someone new, does not play taking games. At 18 months, he's not standing alone. If he's not standing alone, forget about with support, even if with support, not attempting to walk at all without support. His handedness, usually handedness comes by 2 years of age. If handedness is very prominent at 18 months, there could be a case of infantile hemiplegia or cerebral palsy. Fine motor, does not attempt to tower blocks if he's not holding or scribbling with crayons. Language, no clear words at 18 months, cannot understand short request, and lack of proto-declarative pointing. At 2 years, unable to run, unable to use stairs holding, unable to throw ball. A lot of children with muscular dystrophies might be picked up at later ages when we almost think that these milestones are done and over with, right? Gloss milestones. You come across children with muscular dystrophies, with muscular ailments being now pointed out then. Like we see Gowers sign usually at 6 to 7 years. So fine motor, no interest in feeding and dressing. Language at 2 years, no jargon language, vocabulary less than 50 words, not putting two words together. Now, here I would like to mention one thing, that now the vocabulary at 50 words, I don't see many children at 2 years having this kind of vocabulary. Maybe because of the advent, because of the huge invasion of our iPads and mobile phones and their engrossing. That is why the American Academy and even the IAP has very clearly said no screen time before 2 years. And that would be the end of our talk. Any inputs from first Dr. Sharmila and then the audience? Ma'am.
Can I just add two small sentences over here? So what Dr. Ashish just talked about, the red flags, it's just like a draw a parallel to a bell-shaped curve. So in a bell-shaped curve, you know that you have children between +2 and -2 standard deviations. And if you have a child between -2 and -3, then आपके antennae खड़े हो जाने चाहिए. So the same thing is this, that a red flag basic. So if you have a milestone and the milestone, the range of the milestone is that it should appear by say around 4 to 6 months, and the child is 6 months and 1 day, you don't start getting panicky about it, or you don't let the parent get panicky about it. But if the age of appearance extends beyond -2, say it should come by 4 to 6 and it's now 8 to 9 months, then definitely it's a concern. So the way a child who is coming to you regularly in your follow-up, you should not identify the child when he comes with severe anemia and congestive heart failure. You should pick up the mild anemia when it's mild. Similarly, if a child is coming to you, there is no, I mean, you should start detecting when the child is going a little off the trajectory, and then see whether it's because of environmental causes. And if it's not, then you keep on following and tracking the child. And the moment you feel that the red flags are approaching, you can start early intervention, or you can start, even if you don't tell the parents, you can start becoming. So it's as Dr. Ashish said, you have to be like a forensic expert, like a CBI agent. You have to pick up the kids as early as possible, because all of us know that if it's due to a reversible cause, then great. And if it's due to something pathological, the earlier the intervention, the prognosis is better. And another figure that Lancet came out with is that almost 43% of children belonging to between 0 to 5, especially from low and middle income countries like ours. So 43%, roughly, that means almost 1 in 2 children are not gaining their developmental potential, that developmental trajectory that which you see in Ghai, they are not reaching where they should reach. And most of the causes are because they are not being picked up in time. So that is where our responsibility as healthcare professionals who are dealing so closely with children and their families come into play. So thank you, Dr. Ashish, for a wonderful presentation. So now, how do we go about it?
Always a pleasure to have you as a moderator. I'm so used to it now. I think in the whole year we've done four moderations with you. Any questions or any this thing from the audience? Anyone in the chat?
I can't
thank you, Ashish and Sharmila.
See any other questions in the chat?
There are no questions in the chat.
Yes.
Thank you very much, Ashish and Sharmila, for the wonderful Jugalbandi, as I call it. Complimenting each other with
repeat it again, sir. It may be ADHD. I think I was just wondering if we can do it ADHD with Dr. Sharmila.
सर मैं भी यही कहने वाला था, जुगलबंदी के बाद तो सवाल बचता ही कोई नहीं है, सवाल कोई करेगा.
सर आशीष मेरा बहुत अच्छा दोस्त है, हमारी बहुत अच्छी पार्टनरशिप है.
हाँ, तो इसलिए कोई दिक्कत ही नहीं है. चलो जी, good.
All that I say is that I tell all my postgraduates that whatever the case, whatever the cause for admission in the hospital, for my sake, you take care of the patient. But for your own sake, in every patient, always do a developmental assessment and also a nutritional assessment, so that when you are in the examination, you function on the developmental assessment and the nutritional assessment at the spinal level. Because when you are presenting your cases in the examination, one can make out whether you have done this sort of an activity or in routine, or you are doing it for the first or the second time during the examination. And that puts you in a very bad spot if you are not able to do the developmental assessment or the nutritional assessment properly. So I think I need to underline that every patient in the ward should be subjected to a developmental assessment. Luckily, nowadays, every pediatric history sheet has a full-fledged portion on developmental assessment, which is written there, and you just have to tick mark and do hone your skills. That
So
is
that's what.
very, very, very important.
So actually वही था जब आपने बोला कि on milestones, and I told Dr. Sharmila that on milestone I was a little this thing कि normal milestones, but when you probe our own DNBs and our own PG students, we realize they are so much into inborn errors of immunity and inborn and headache chikashi and this and that. But so the basic pediatrics is immunization, development, and nutrition, which we were taught in the first year. And that is still the most important thing. Diagnosing or doing ECMO is 1 in 1,000, right? I mean, that's there, but वो कितने pediatrician करते हैं सर? वो आप जैसे लोग जो गंगाराम में वो ECMO करते हैं. But 99% of the population needs this development part to be really taken care of. And unfortunately, they start nowadays when our DNP students, you see them studying, they won't be studying this thing. They'll be studying acyanotic or cyanotic CSD first. So I tell them, पहले milestone तो पढ़ ले boss, पहले कम से कम nutrition तो पढ़ ले, then you go to other things, right?
I'll give you an example, Ashish. Today we were doing the FNB exam for HEMONC, and when we were reviewing the papers, and we were discussing it much before we reviewed the papers, and they said, what is your take on current scenario of postgraduates? And I said that, because they are not exposed to the OPDs properly, they are very poor at managing basic things like anemia, etc. But they are excellent at managing hemopoietic stem cell transplant. और जब हमने papers भी review किए, तो in the answer which was given, what was absent was the basic funda, basic things, CBC, peripheral smear. उसका जवाब नहीं लिखा है, मगर high-end stuff like, high-end monoclonal antibodies, वो सब कुछ लिख दिया. So that is what the problem is. We have to focus, at least in the first year, on the basic things. Basic things.
Developmental delay पता है, लेकिन development normal नहीं पता. मतलब
delay दे दो.
But milestones वाले में गायब. And I think
आशीष, developmental delay भी तब पता चलता है जब वो कान में फूंक मार दी जाती है during examination. Anyway, thank you very much, all of you. Wonderful experience, and thank you, Dr. Bhandari, for pitching in, and Dr. Singaravelu also thank you, although he had to leave early, but his inputs were also very important. Thank you very much, and good night, everybody.
Thank you, Dr. Bhandari. Thank you so much.
Good night, Ji. Good night, friends. Good night.